Hello, so today we're going to be discussing a pharmacoeconomic evaluation of the study Economic Evaluation of Bevacizumab for Treatment of Platinum-Resistant Recurrent Ovarian Cancer in Canada. And this presentation was created by Group 30, which is Briana, Taylor, Shakira, and Stephanie. So we started by analyzing the appropriateness of the title. So if we look at the title, what bevacizumab or the intervention is being compared to is not evident in the title, so we don't know that it's being compared to a certain type of chemotherapy. We also can't tell that bevacizumab is being used along with other chemotherapy in this study, so that's not clear from the title. However, we do know that this was conducted based on a Canadian perspective. The study type is not indicated, so this is a cost-utility analysis, but that's not evident from the title. The disease studied is recurrent ovarian cancer. The setting was not indicated, so we had to go to the major Aurelia trial to find that the study was conducted from data in 121 study locations from 14 European countries. However, the title had a low risk of bias because it's not pointing one way or the other to say that bevacizumab was cost-effective or not. So then we looked at the question and the objective that the authors were trying to study. So the objective of the study was to conduct a cost-utility analysis from a Canadian public payer perspective to determine the cost-effectiveness of bevacizumab, a newly available treatment option for recurrent ovarian cancer. So in the study, they did go through and discuss why they're looking at bevacizumab plus chemotherapy. They also specifically outlined which chemotherapy was used in the comparator group, which was pegylated liposomal doxorubicin, paclitaxel, or topotecan. The specific doses of the drugs being used and the number of cycles was not cited in this article, although we may assume that it would be in the study criteria in the Aurelia trial. But overall, because bevacizumab has been approved in Canada to be used in platinum-sensitive and platinum-resistant recurrent ovarian cancer, this appears to be an appropriate intervention to be studied. So moving on to the methods and the use and implications of the study perspective. So it's clearly stated that this economic analysis was meant to analyze the expected costs, effects, and cost effectiveness of the currently available pharmacotherapeutic options within a Canadian healthcare system perspective. So essentially the payer perspective is indicated, and it's only going to take into account direct medical costs. This perspective, when compared to the societal perspective, may undermine the benefits of the treatment because it's not looking into any benefits the patient may receive in terms of increased productivity or less intangible costs, so things like feeling fatigued, having poor side effects, or reactions to the drug. So that's not taken into account from this payer perspective. Moving on to relevant costs. So as we mentioned earlier, it includes all direct medical costs. So these were things like medication costs, the cost of the visits, blood tests, infusion costs, and the cost of healthcare professionals contributing to the care, but direct non-medical, indirect, and intangible costs were not included. So because it is a payer perspective, these costs that were included were appropriate. In terms of relevant outcomes, so we haven't mentioned that this is a cost-utility study. So one of the outcomes they're looking at is quality-adjusted life years gained. This is appropriate to use for the cancer disease state because it's incorporating not only the effect of the treatment on length of life, but also quality of life. It also can be used to compare different therapeutic areas. So instead of something like blood pressure that's used in hypertension, where you can really only use it in hypertension, quality-adjusted life years is something broader and can be used to compare interventions for different disease states. It's also less specific than other cancer-focused outcomes like progression-free survival, which are also not used in other therapeutic areas. And then they calculated the incremental cost-utility ratio, and that determines cost for quality gained, and that's appropriate for the study objective to determine which treatment option is more cost-effective, while also taking into account quality of life. So in terms of adjustment and discounting of costs, so they actually employed both in the study. The trial was performed from 2009 to 2014, and it was appropriate to adjust these costs in order to get to 2016, which at the time would have been more of a present value compared to past values. So they state that all unit costs were inflated as necessary to 2016 Canadian dollars. They also needed to use discounting because they employed a 7-year time horizon in their base case analysis. So essentially what they were doing is they knew that the prognosis of some patients who are still alive at the time of data collection, they knew that they didn't have data for those patients, so they were projecting into the future. So what they did is they employed a 5% discount rate as per the Canadian Agency for Drugs and Technologies. So they just explain here that total costs for each treatment arm were estimated over the time horizon of the model by aggregating the cycle-specific costs associated with treatment, healthcare resource utilization, and management of adverse events according to the number of patients in each health state. So we believe that both adjustment and discounting were needed based on the types of costs and when they were collected. In terms of assumptions, so the cost of adverse events that were used in the model calculations was estimated by multiplying the proportion of patients with adverse events in each of the 2 treatment arms as reported in the original trial by the unit cost of each adverse event. We felt that this was reasonable to do to create that average cost for management of adverse events, because it would have been difficult with having 121 different sites to figure out how many patients had each adverse event and then how much did it cost at that specific institution to remedy the adverse effect. So we felt like this was a more efficient way to estimate the cost of adverse events. We felt that was appropriate. And then we also state that the analysis also assumed that per episode costs of adverse events for leukopenia management are equal to neutropenia, and the authors say that this could have biased the results, but they assume that the assumption impact would be minimal. And the cost and outcomes references were properly referenced from the Aurelia trial. So if they were not properly referenced, that would be something we would be concerned about, but the remaining costs we can assume were not assumptions because they did have references. So moving on to the results. So interpretation of the results. So we have the addition of Bevacizumab would result in a higher cost. So we can see the 79,000 Canadian dollars compared to around 54,000 Canadian dollars with chemo. But they did result in better outcomes because the quality of adjusted life year was higher. They calculated the incremental cost utility ratio, and they found that to produce that additional quality adjusted life year, it would cost 213,424 Canadian dollars. However, the willingness to pay threshold was only 100,000 Canadian dollars. So although the treatment did provide benefit, it's unlikely that payers would be willing to pay for the treatment, so it's not considered to be cost effective. So the impact of study results in clinical practice. So the results do indicate that the Canadian payer is not inclined to pay for this agent because they would not see the benefit being worth the cost that they're going to pay based on the willingness to pay threshold that was used in the article. The results may not translate to other countries, so other areas there could be different costs in terms of how much the treatment costs, the infusion costs, how much it costs to treat adverse events, but also the willingness to pay threshold may vary. It could be less for less wealthy countries, and it could be higher for countries that have greater wealth. In terms of a sensitivity analysis, so it was conducted by the study and it was very thoroughly explained. So they did a sensitivity analysis to account for uncertainty in model assumptions, and the ICERs were most sensitive to Bevacizumab, unit cost and outcomes, discount factor, and the time horizons. So we recognize the conclusions of the study may vary related to these variables, and that could potentially limit the generalizability of the study results. Because essentially what this means is that if you change the values of some of these variables that are sensitive, then your overall conclusion could be different. So we recognize that that limits the generalizability. In addition, the results indicated that Bevacizumab is not cost effective at either 50,000 Canadian dollars or 100,000 Canadian dollars for quality adjusted life years, so 2 commonly cited threshold values. And so they were just showing this to show that they were transparent about the sensitivity analysis. They provided thorough detail, and it's very important to include a sensitivity analysis in an economic evaluation, and it leads to more trustworthy results since it accounts for potential variations in costs. However, other than those 3 that we mentioned, the remaining parameters were not sensitive to the analysis. So some study limitations. So the authors were also pretty thorough when they discussed these. They addressed several limitations, the most profound being limited generalizability. So they addressed the fact that randomized controlled trials, their environments are very controlled, which limits generalizability. The perspective was a Canadian healthcare system, which means that it may not be able to be applied to other countries such as the United States, where we have a very different payer setup. for the country and for reimbursement. So for the conclusion, they concluded that based on the results of the economic analysis, bevacizumab is not considered cost-effective at the willingness to pay thresholds below approximately 200,000 Canadian dollars per quality gained, and therefore may not be a cost-effective treatment option for women with advanced recurrent ovarian cancer in Canada. So the conclusion is appropriate. You can very clearly see from the numbers that the quality-adjusted life year, the cost for that is higher than the threshold. And it is appropriate based on the location of Canada and also from the payer perspective. In this final conclusion, they could have been more clear about the comparison treatment. So what is the alternative? What are the alternative chemotherapies being used in patients who did not receive bevacizumab? But in general, we felt that this was a clear statement to providers reading this evaluation that at this time in Canada, bevacizumab would not be considered to be cost effective.